Hey everyone, welcome to the first breakout session. So I am excited to introduce Dr. Keith Kaufman. Um, for those of you who were in the last session and heard my wife Laura talk about Bryson and his Neurostorms, you'll know that this next speaker is very important to our family. We learned actually, I was talking to people in another rare disease organization, one of the sodium channel disorders, who told me that they'd been in contact with Dr. Kaufman, and I was telling them about these episodes that Bryson had that we were treating as seizures because a neurologist thought maybe they were seizures, even though they were never confirmed on an EEG. And they told me about Dr. Kaufman and his work in um, identifying a genetic basis for something called paroxysmal sympathetic hyperactivity, which Dr. Kaufman will talk about, but as I understand it, it's a combination of dystonia and dysautonomia. And we were able to put Bryson on meds, and it's really changed Bryson's life and changed our lives, finding out what he had and then finding the right medications. The last couple months have been challenging again with Bryson being sick and not eating or drinking for a while. The storms really have come back, but I think that in the past few days we're starting to get him back on track. So that is great news. So, and also Dr. Kaufman, last time you spoke with us, you were in Kansas City. Now you're in Rochester, Minnesota at the Mayo Clinic. So thank you for joining us.
My pleasure. So, hello, everybody. My name is also Keith Kaufman. And as Keith MacArthur said, I have recently relocated to Mayo Clinic in Rochester, Minnesota, after a decade in Kansas City. So we're going to talk about two of my favorite topics in neurology, autonomic dysfunction and movement disorders, and how they relate to the GRICON disorders. Okay, so I have no financial relationships to disclose. I'm not going to talk about any medications by name, so there's no discussion of anything off-label because it's all related to symptoms. And since we've got an international audience, not knowing what medications are available where. Okay, so the key points of today's talk. Number one, what is the autonomic nervous system? Everybody in this audience knows the central nervous system, that's the brain and the spinal cord. But the autonomic nervous system is what we're going to spend the bulk of the time talking about. What parts of the brain regulate autonomic output? So what parts of the brain really make this system do what it's supposed to? And what's the phenomenology of autonomic dysfunction? What do you see when this part of the nervous system misbehaves? And then why might patients with GRICON disorders develop this problem? Okay, so the autonomic nervous system is responsible for the automatic functions of the human. It does the things that we don't have conscious control over, or we have minimal conscious control over. So heart rate and how hard your heart beats, respiratory drive, or how fast you breathe, temperature regulation. And I know this is a big one for many in the audience, problems with temperature regulation, temperature instability. Intestinal motility, so moving things from your mouth through the bottom of your intestinal tract is a big part of autonomic function. Bowel and bladder control, sweating, skin vascular tone. So whether you're red and flushed or whether you're pale, cool, and blue is also under a large component of the autonomic nervous system. And then arousal state, how awake and alert are you? Sleep-wake cycles, which for probably most everybody in the audience who's a parent or family member or caregiver knows that this is a huge part of the experience. And then pain response. Okay. So this part of the nervous system, which is the third part of the overall nervous system, it itself has three branches. So the biggest one is the intrinsic enteric nervous system. So the intestinal tract from the esophagus to the rectum has its own nervous system inherent to itself. And from the moment you pass anything past your throat where it has to start moving down your esophagus, it's under the control of the autonomic nervous system in terms of how well that goes. And then your sympathetic nervous system is your fight, flight, or freeze. So when this system goes overactive or super active, we'll see what the phenomenology is there. And then you have a parasympathetic system. This is your rest and digest system. This is the system that allows you to be calm and slow things down and be effective in metabolizing. Okay. So when we look at the autonomic nervous system, this figure here, so we all know the brain and spinal cord. On the right side of the screen, where the sympathetic nervous system is in red, everything from pupil and saliva and sweat and breathing and heart and liver, all the way down to bowel, bladder, and gonads is innervated and controlled by the autonomic nervous system. And these two branches, the sympathetic in red and the parasympathetic in blue, live in a balance with each other. They have to work in concert and they have to work in a balanced fashion, or else things in the body don't work properly. So even though it's the autonomic nervous system, and even though it's automatic, it's not autonomous. Okay, so there are multiple brain regions that help to regulate and influence the activity of autonomic outflow. So one of the areas we'll talk the most about today is a tiny structure deep in the center of the brain that is exceptionally powerful when it comes to autonomic regulation, and that is the hypothalamus. So the hypothalamus has central control for autonomic function, hunger and thirst, sleep-wake cycles, temperature, heart rate, blood pressure, blood vessel tone, pain response, sweating and drooling. This one little area of the brain has multiple subnuclei, and each of those has a distinct function related to these different areas of body homeostasis. Okay. It's also responsible for hormone release, growth hormone, triggering thyroid hormone, triggering your sex hormones. Then moving deeper into the brain, down in the middle of the brain, we've got the substantia nigra. This is where the dopamine neurons live in the brain. Dopamine is also responsible for heart rate, blood vessel tone, intestine, reward, movement, thinking, memory. And then further deep in the brain are the Raphe nuclei. These are a group of nerve cells where the serotonin neurons live in the brain. Serotonin is pain, mood, and vomiting, and a little bit of function of blood vessel tone. And then down at the base of the brain, just before the top of the spinal cord, you have the medulla, which is responsible for heart rate, breathing, sneezing, vomiting, all live in that area of the brain. So I said those systems have to live in balance. And we're going to talk about, what happens when that system falls out of balance. So Keith alluded to my work with other neurodevelopmental disorders, other genetic disorders. And I had the privilege of publishing a paper a few years ago with my colleagues, Ann Berg and Deborah Gabler-Spira, about problems with autonomic dysfunction in a group of children who have developmental and epileptic encephalopathies. And this was a heterogeneous group. This was not kids with all the same disorder, or even the same type of disorder. And we queried them using a well-established autonomic disorders questionnaire and found that when we looked at surveying parents, We had 18 different symptoms that emerged in 6 different domains. So cardiac, respiratory, temperature, GI, and then other like sleep wake cycles, other like level of arousal. And what we also found is that 81% of kids who were surveyed by their parents had problems with autonomic regulation in this group of children with DEEs. An impairment, the dysfunction in the autonomic nervous system causing functional impairment in at least one domain was present in 90% of these children. So not only were these symptoms highly prevalent, but they had a tremendous negative impact on day-to-day quality of life, as Keith alluded to in his opening. Okay, so that's just baseline, right? Things just don't work really well. That doesn't get to the storming kind of phenomenon that Keith alluded to. So what happens when the balance gets severely disrupted? So what happens when this occurs, right? So, and you see that diagram from earlier on. What I'm showing now is on the left, parasympathetic activity going down and sympathetic activity just skyrocketing 3-4 times, the output of the parasympathetic function. And what you see here, what this results in is what are called paroxysmal sympathetic hyperactivity. That's what we call it now. Okay, it has gone through many iterations in the medical literature throughout just my 20-some year career. When I was a very young trainee, the term that was used at the time was thalamic storms. People thought that these kind of storms came from the thalamus. The thalamus is the major relay station in the brain. But when people looked at thalamic activity and children and adults who have this problem, realized thalamus wasn't the problem. It's really the hypothalamus that's the problem. Okay. It's also been called autonomic storms. And the reason for that is very simple. What happens here phenomenologically is you get surges of autonomic output, sympathetic output. Now, this is well known. It's been known for decades. My colleagues and myself in the world of neurology, neurosurgery, and rehabilitation medicine have known this entity very, very well because we see it in all kinds of different diseases. Until we started to really recognize through modern day genetic testing that the developmental and epileptic encephalopathies and the other neurogenetic disorders existed. It had previously been thought that you only saw this in people with head injury or spinal cord injury or brain tumor. We now know that it's a huge part of the phenotype in these neurogenetic disorders that we're talking about today. It's never really been studied scientifically well in patients with developmental disorders, and that's part of the reason that I talk about this to audiences is to A, make them aware, B, get our scientific colleagues who do the research more aware of this. And recently there was a consensus paper published a few years ago about how to diagnose this entity. But the diagnostic criteria currently are only for adults and after brain injury. We have yet to design or devise a true good scoring system for A, kids, and B, children with neurogenetic diseases. Okay, so what happens in these events? What happens is you have sudden onset of the increase in temperature, heart rate, respiratory rate, you get flushed, you get sweaty, you get agitated, often with abnormal body posturing, which from a movement disorder neurology standpoint, I can tell you is the phenomenon called dystonia. As Keith mentioned, and as patients have come to me from all over, often mistaken for seizure. The key thing, unlike seizures, these movements can last for hours at a time, and they do not respond to anti-seizure medications, whether it be your anticonvulsants or medications like benzodiazepines. They're just unrelenting. And the EEG does not change whenever these events occur. Okay, so on a seizure, you can see the episodes start, EEG changes, you can say, what's being happening here is this abnormal brain activity is driving this phenomenology. I can treat this with an anti-seizure medication. The EEG doesn't change during these events. Very much they look like seizures, but they are not. Okay. So I'm going to show you an event of sort of a classic event of what these look like. So you see this little girl. She's very flushed. Hopefully you can hear her screaming. You can see her toes curled down. You can see her left hand sort of postured and locked. Okay. And I'll show you this again and not talk this time. Okay. So this little girl had these events. They would last for hours at a time. I first met her many, many years ago now, when she had one of these events so severe that she actually, because of her dystonia posturing, ended up self-fracturing her femur from her dystonia. And that's really what started my work and my passion for identifying this is meeting this little girl and her family who has a sodium channel mutation. And it's really what propelled my clinical and scientific interest in helping patients and families affected by this. Is meeting her so many years ago and the trauma that she and her family had from this not having been identified. Okay, so we already talked about the fact that, when these episodes happen, you can't stop them. When they have started, you cannot stop them. Okay. Well, how do we prevent them, Dr. Kaufman? What kind of things can we do? So number one, room temperature. Many patients who have difficulty controlling their body temperature need the room to be cooler than the rest of us would like it. So that's a big thing in patients. If you find that somebody who has PSH, when it's cooler outside, they don't have as many episodes, find a way to keep it cooler. If there's a room of the house, like in my house, that's a reverse 1.5, the bottom floor of the house is pretty much underground. It's cool year round. Low stimulation environment, low noise, low light. We who don't have these kind of events don't think about this all the time, but processing light, processing sound is something that our brains have to do nonstop while we're awake. And if our brains are not running at full capacity because we have one of these conditions, processing bright lights and loud noises can be overwhelming. Okay. Work to try to regulate sleep-wake cycles. Yeah, right, Dr. Kaufman. Have you met my child? How are we going to regulate sleep-wake cycles? So besides medications, things like room lighting and environment and quiet, that's the kind of stuff I'm talking about. Are we making the bedroom environment cool enough, quiet enough, and dark enough to promote sleep? Bowel and bladder control. If you have constipation or urinary retention, that is a source of discomfort. That is a stress on the autonomic nervous system, and that is going to make these things way more common. And then evaluate for pain generators, okay? One of the things I do with all of my patients who have mobility differences, regardless of diagnosis, is whenever I examine them, I look for areas on their body, areas on their skin that are red or puffy or show any sign of injury. So even little things can be pain generators, right? The footrest of a wheelchair, the back of a wheelchair if we've kind of outgrown it, the lateral side supports if they're sort of poking now into a rib because we've grown a couple inches in height. So those are the kind of things to think about. right? When it comes to treating these episodes, there are ways to effectively prevent these episodes pharmacologically and medically, okay? We're not dealing with high-level science, however, in terms of any clinical trials, any placebo-controlled trials. What we're dealing with are case series or anecdotal reports from physicians like myself and others who see patients who have these conditions. Because, as I said, being able to identify this, there's a big knowledge gap, and therefore being able to do any sort of standardized trial or clinical investigation has been greatly limited by the underdiagnosis of this phenomenon in patients with GRI disorders and other neurogenetic entities. Okay, we already talked about the fact that trying to stop them, abortive therapy. Okay, I'm having an episode. What can I do to stop it? Medically, nothing has been shown scientifically to work in that regard. So we have to prevent it. There's very little data, as I said, about what's effective. So we use medications typically that decrease autonomic output, medications that decrease the release of dopamine, medications that decrease the release of norepinephrine. And those two entities also feed into the epinephrine system. So dopamine is metabolized into norepinephrine, which is metabolized into epinephrine. And if we can decrease the release of those, we can decrease the frequency and severity of these events. Use medications that treat pain. And what I'm talking about here is non-opioid medications. So there are many medications in the world of neurology that we use to treat nerve type pain, because nerve pain of one way or another is a phenomenon that we see across the lifespan with many diseases. The other thing we need to do is to treat movement disorders, dystonia, if it is present, because that movement, you saw that little girl's foot. Her foot was locked in place. Her toes were curled under her foot. If you tried to extend her toes into a normal position or stretch her ankle into a normal position, the muscles in that foot and ankle are rock hard, spasming uncontrollably. So when you identify somebody who not only has PSH, but has a movement disorder like that, treating that movement disorder and controlling the dystonia will decrease the PSH episodes quite significantly. And when we use medications to treat dystonia, we use, again, medications that act on dopamine, medications that act on acetylcholine. And that's the only time today you'll hear about acetylcholine, because there's two rare medications that we use to treat dystonia that act on that agent. And then very critical to the GRI disorders is medications that work on GABA, right? GABA, as you'll see as we go through, is one of the biggest players in the world of autonomic neurology and movement disorders neurology that we're going to talk about today. So we'll transition into why might patients who have GRI disorders develop PSH episodes. What about the hypothalamus? So I told you earlier on that the hypothalamus is a deep structure right in the center of the brain. So the hypothalamus is this wee little guy over here in green, okay? We're talking about a structure that is exceptionally small when you look at it compared to the cortex of the brain, okay? Incredibly small compared to the cerebellum, even incredibly small compared to the pons or the brainstem. Yet it contains all of those nerve cells that control autonomic function. It's a very unusual design, okay? We weren't the designers. We don't have any input or insight into why it was designed that way, but that's the design we're dealt, okay? Is there any evidence that if you alter glutamate receptors that you can affect hypothalamic function? So there are numerous papers that talk about the hypothalamus and glutamate receptors. So this is a paper that talks about the participation of NMDA receptors in gastric erosion, so alteration and irritation of the stomach. A paper here that talks about NMDA receptors and the hypothalamus and maintaining vasomotor activity. So the vasomotor is the muscle activity of vessels in high blood pressure. Okay. Here's a paper that talks about glutamate receptors lacking AMPA receptors, which increase the excitability and increase drive in hypertension. So again, back to high blood pressure and sympathetic tone by altering glutamate. And here's where sleep gets into the realm. NMDA receptors in the lateral preoptic hypothalamus, essential for maintaining normal sleep, REM and non-REM. And if you modulate glutamate, it blocks serotonin, which affects sleep-wake cycles. Okay, so yeah, there's tons of literature going back, 22, 23 years now, showing that if you alter glutamate activity in the brain, you directly affect hypothalamic activity and directly affect autonomic outflow. So what about the other symptoms in GRI disorders? So this comes from the CureGrin website. When we talk about the other conditions, developmental delay, intellectual disability, limited speech, autism, dystonia, cortical visual problems. Some of these I can't blame on the hypothalamus. The neurons that control those don't live there. So what about downstream? We talked about immediately if you alter glutamate, what happens in the hypothalamus. What about downstream? Because we know that glutamate acts on the surface of the brain as well. It acts in the cortex. So that's where we see a great deal of parallels between the pediatric neurotransmitter disorders and the GRI disorders. And when we look at the symptoms of pediatric neurotransmitter disorders, and this comes from an article by two friends, Mike Gibson and Phil Pearl, both of whom I've had the pleasure to meet over the past couple decades. What we see in neurotransmitter disorders, hypotonia, one of the biggest findings in these conditions, epilepsy, autonomic dysfunction or dysautonomia, GI dysfunction, movement disorders. Almost every patient with one of these conditions comes to see a child neurologist who's a movement disorder expert because the movement disorder is so prevalent. Oculogyrate crisis, which is an odd motor disorder where your eyeballs, your globes get stuck in place because you can't voluntarily control them. Sleep disturbance, irritability, intellectual disability, developmental delay, and you can throw autism in there too. And the reason for that is the functions of the neurotransmitter systems. So we already talked about dopamine as it relates to autonomic function. We take dopamine out of the realm of autonomic function, motor control, attention, focus, learning, right? If you are dopamine deficient, you don't move well. You may have involuntary movements. Your attention and focus are greatly impaired. Your ability to learn is greatly impaired. Norepinephrine. If we don't have enough norepinephrine, you don't have good levels of alertness. You don't have high levels of arousal. You have inappropriate fight or flight responses. Epinephrine, fight or flight, pupil control is a huge piece of the epinephrine. And I imagine that there are many of you like, oh, that's why the pupils get big with these. Yes, exactly. And then blood sugar control. Epinephrine is tightly related to glucose metabolism and glucose homeostasis. When norepinephrine is off, glucose control can be off. And then serotonin, we talked about nausea, vomiting, pain. but mood, thinking, learning, appetite, and sleep. So most of human existence in these four little chemicals. Okay. So why might GRICON disorder symptoms resemble neurotransmitter disorders? Okay, so I'm going to walk you through now my favorite part of the brain as a pediatric movement disorder neurologist, which are the basal ganglia, and how the basal ganglia and the chemistry of the basal ganglia work in everyday function, and how when you alter different parts of basal ganglia function, you get wide-ranging symptoms that affect every part of how your body works. And then sort of walk you through why, theoretically, patients who have GRICON disorders have such challenging problems with autonomic regulation and movement and cognitive function and everything that we're talking about today. Okay, so this is a cartoon, free cartoon diagram of the basal ganglia. So down here in the center foreground, your basal ganglia are in different shades of reddish, pinkish, okay? So there are four structures, okay? You've got your caudate nucleus, your putamen, your globus pallidus, internal and or external and internal segments. And when you look at the basal ganglia from a side view, they're this bulky C-shaped structures that come down through the center of the brain, okay? What's their job? What is their primary role? Okay, I want everybody to understand that the basal ganglia are equal to the brakes of the brain. Their primary job is to keep involuntary movements from happening. When their function is disrupted, involuntary movement disorders occur. Okay. In all involuntary movement disorders that arise from dysfunction of the basal ganglia, you get symptoms besides movement disorders. Okay, because the basal ganglia have circuits that influence and help regulate sensory control, cognitive processing, emotional response, eye movements, all in these little structures deep in the center of the brain. Okay, so let's walk you through some well-known examples of basal ganglia disorders and talk about A, the motor system problems that happen with them, and B, the non-motor symptoms that happen, and how the problems we see in patients affected by the GRICON disorders really parallels what we see in the movement disorders world. Okay, so this is from my absolute favorite textbook of neuroanatomy. Yes, I have a favorite neuroanatomy textbook. I've read and dissected many of them over the course of my career. Dr. Hal Blumenfeld from Yale University has written the best, in my opinion. And Dr. Blumenfeld has this now very famous diagram of the basal ganglia that every time I see a patient who has a movement disorder, this is the picture that comes into my brain. And this is the picture that I think about when I treat any patient who's got a movement disorder. And the reason is, what Dr. Blumenfeld so elegantly shows is the cortex of the brain. So the neurons, what we think of the brain, think of the cortex. And from the cortex, you get signaling to the basal ganglia from glutamate. Okay, so there's our glutamate story. Different from the hypothalamus, we're now talking glutamate to basal ganglia. And next in line is the striatum. So the striatum is what we call the caudate and the putamen together, because when you look at them under a microscope or an MRI, they're actually connected in a stripy kind of pattern. Okay, and then you see dopamine, which we've talked about extensively, and you see acetylcholine involved in the basal ganglia as well. And then you see glutamate back here at the bottom going from the thalamus back up to the surface of the brain. And then everywhere in here, you see GABA, 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 okay? So these neurotransmitters, glutamate, dopamine, acetylcholine, GABA, modulate everything that the basal ganglia plural. And by modulating the way that the neurochemistry of these structures work, or the anatomy of these structures and certain diseases, which we'll talk about soon, you get wide-arching symptoms that affect the entirety of someone's existence. Okay. So we'll start with the prototypical basal ganglia disorder. Okay. Everybody knows about Parkinson's disease. What happens in Parkinson's disease is that you lose your dopamine-containing neurons in the brain. Everybody who's seen videos or knows of someone with Parkinson knows that their movements are quite slow whenever they attempt to walk. Whenever they are sitting at rest, they have an involuntary tremor. Whenever they talk, their voice is very low. Whenever you look at them, they don't have any emotional expression on their face. Okay? That's all the motor symptoms we see. Okay? Way before the motor symptoms ever show up, people who have Parkinson have other symptoms that arise. They lose their sense of smell. They start to have memory problems. They start to have unsteadiness of posture. They start to have problems when they go from sitting to standing, their blood pressure not regulating well. As the condition progresses, they lose memory. They lose the ability to form new memories. They often end up with a dementia kind of picture, okay? And that's just by knocking out the dopamine input to this circuit, okay? Another well-known, not as well known as Parkinson, but very well known in the neurology movement disorder world is Huntington. So what happens in Huntington is you get loss of the neurons in the caudate. So you lose part of that striatum. And when Huntington starts, everybody thinks of Huntington, if you've seen it before, as a movement disorder. Patients end up with chorea, which is a writhing, dancing kind of movement that's extremely debilitating. Life-altering loss of ability to control motor function. But years prior to the onset of the movement disorder, patients with Huntington develop severe behavior and personality change. They become very disinhibited, highly socially inappropriate, and then develop cognitive dysfunction, memory loss, dementia as part of the picture. And that's just by losing neurons in a small part of this system. There are other disorders. There are disorders of GABA metabolism. And as I mentioned earlier, Dr. Philip Pearl. Dr. Pearl is one of the world experts in what's called succinic semialdehyde dehydrogenase deficiency, or SSADH deficiency. That's a typo there. I will fix that. It's SSADH deficiency, not AADC deficiency. And children with SSADH deficiency have hypotonia, movement disorder, epilepsy, eating problems, all from not being able to make appropriate amounts of GABA in their central nervous system. So what happens when you alter glutamate function? Well, we don't know, right? So we know that in the GRI disorders, we've got problems with glutamate metabolism, glutamate receptor activity. We don't know what happens in the basal ganglia to explain why we have all these things. We know phenomenologically, movement disorders, autonomic dysfunction, learning, memory, everything we talked about occurs, but we don't know what happens in this region of the brain. And that's where our basic science colleagues who do the animal modeling and look at the brains of animals affected by mutations can really help us to understand what's going on downstream of the cortex to explain what's happening here. Is it a neurotransmitter dysfunction? Or are we having changes to the basal ganglia at the microscopic level because of the abnormal signaling in the cortex? We don't know yet. Okay. So, closing thoughts from my standpoint. Autonomic nervous system must work in a balanced way to effectively work at all. Disruption of the autonomic nervous system causes wide-ranging symptoms, and I hope you've got an understanding of that now. PSH, highly under-recognized and undertreated disorder in patients with genetic disorders. Abnormalities of hypothalamic function definitely result from dysfunction in glutamate receptors, and the literature is very strong there. What we don't know is whether or not other neurotransmitter systems, basal ganglia, dopamine, norepinephrine, may be a downstream effect of GRI mutations. And is that why we're seeing all this phenomenology that really gets into the movement disorders and cognitive neurology realm, in addition to the epilepsy that's so powerful? And with that, I am through, and I'll take any questions because it looks like, as usual, I am way ahead of time. Okay.
Well, that's great that you're ahead of time because there are quite a few questions.
I figured there would be.
But first, I just want to say I think this is the fourth time that you've spoken to our families, and I think it's just amazing that each presentation you kind of assemble more information, and we've gone, from the start where you helped us. Helped many people by identifying this symptom, and potentially learning how to treat the symptom, to a place now where you're presenting us with a potential cohesive theory of many of the symptoms. So thank you very much. This was terrific. So I will go over to the questions. And so the first one is asking about, can this happen to a child who doesn't have dystonia,
Yes.
but has other symptoms like a child with hypotonia?
Oh, yes. Oh, yes. So, what I've learned over the decades is that the phenomenon of PSH, I present it at the absolute worst that it could be, okay? But I can say with high confidence and decades of experience now that it, like everything else, exists on a spectrum. So I have patients who get sweaty, get flushed, breathe fast, but don't have dystonia. Absolutely. And it does come as a spectrum. I present the most serious so that I cover everything that could be, but it definitely is a spectrum.
Thank you. The next question looks like it was from my wife because she's asking about Bryson. So as a baby, his evoked potential showed abnormal auditory waves and brainstem. So she's asking, could these be associated to the dysautonomia?
The auditory system is its own circuit, separate from the autonomic system. The second abnormal test you mentioned, Keith, was what?
So she says, I actually can't remember, but what she wrote is his evoked potential showed auditory wave issues and brainstem.
Brainstem. So brainstem quite possibly related to autonomic dysfunction, yes. Because brainstem, you're really dealing with medulla, which we talked about and know is a big part of the autonomic nervous system. Yep.
Is there any relationship between sudden sodium spikes outside of illness, like diet, liquid hydration, and the autonomic system?
So that's a great question. And, you know, when we think about the regulation and control over ion flow in the human body, in the human brain, um, the electrolytes, sodium, potassium, calcium, chloride, are very, very tightly regulated. Okay. You take something in that has a high sodium content, your kidneys get involved in filtering it out because the, the body will not let, unless something is highly amiss, will not let what you take in by mouth disrupt what normal levels are. Now, when we think about the sodium channel disorders, those patients have problems regulating sodium activity in neurons because the sodium channels that live on neurons are disrupted. And they are very sensitive to shifts in sodium if you use medications that either activate or inactivate sodium channels. However, outside of those disorders, there's nothing of which I'm aware that says that dietary fluxes can trigger symptoms.
Thank you. Okay, the next question, aside from preventative measures, are there any medications you would recommend to reduce the likelihood of a neurostorm when a patient is out in public, or a person with GRICON is out in public? She writes, in the UK, clonidine seems to have good results, but this medication, a regular dosage. Oh, she's asking, can it be used as a rescue med, basically, clonidine? Or she's saying, can it be used if required?
Right. I have never had any success using clonidine as a rescue medication in any of the conditions that I treat. So in the United States, clonidine is used for treating autonomic dysfunction. It's one of the most evidence-based treatments for Tourette syndrome, and which is another basal ganglia movement disorder. Clonidine takes a couple hours to peak once you take it by mouth. And it also has a fairly short half-life, so it doesn't hang around very long. In the world of tic disorders, it's not one that we ever use for sort of immediate, I need tick suppression right now, because it doesn't work fast enough. We always use it as a baseline maintenance medication.
Okay. What about puberty? The next question, does it affect or increase PSH? Their child seemed more likely to have it since 15.
So yes, so remember on that autonomic nervous system slide that the genitals are part of the autonomic nervous system, okay? There are subnuclei within the hypothalamus that are directly responsible for triggering the release of gonadotropins, gonadal hormones. So yes, puberty and autonomic dysfunction, PSH, go hand in hand. Whether it gets better, whether it gets worse, really, it's come down to patient by patient. And I tell all of my patients, as we're getting closer to puberty, I don't know which way it's going to go, whether it's going to get better or it's going to get worse or it's going to stay the same over the next few years. We'll deal with it as it comes. But yes, 100% puberty sets this off because same region of the brain and same part of the nervous system, hypothalamus, autonomic nervous system.
The next question is from a researcher physician. And this person is asking about if you have thoughts on the relationship to prominent sympathetic storming seen in anti-NMDA receptor encephalitis.
Oh, I've never considered that. I will have to think on that. I've never made that connection or thought about that. Um, yeah.
Which,
sh
which
share my email with that person, Keith, because that's something I've never conceived of, um, to even sort of made a parallel. Um,
and would you mind? I think many people may know what we're talking about, but could you just give a brief description of what the anti-NMDA receptor encephalitis is?
yeah. So this is an autoimmune disorder, first discovered in the late 90s, early 2000s. The physician scientist who's most associated with anti-NMDA encephalitis is Dr. Joseph Dalmo, who was at University of Pennsylvania and is now in Barcelona. Um, this is a disorder that comes with a constellation of profound neuropsychiatric changes, epilepsy, movement disorder, all because you form autoantibodies to the glutamate receptors in the brain. For anyone who's interested about a first person characterization of that disorder, I encourage you to read the book Brain on Fire. This is a book written by a woman who was affected by NMDA encephalitis and her whole experience. And it's a profound read, to really understand. And yes, it just shows when you alter NMDA activity, um, neuropsychiatric symptoms, movement disorder, epilepsy can all be a part of that. And I had never made any connection between that and what happens developmentally. So more on which to ponder.
Yeah, interesting. Yeah, Brain and Fire, I agree, is a great book. It was also turned into a not so great movie.
That's why I mentioned the book.
Yeah. Um, can you talk a little bit about how extreme sensory needs would be affected by neurostorms? The extreme need for oral motor stimulation, vestibular or proprioceptive movement needs. Daughter is GRIN2B, believed to be loss of function, and has extreme sensory needs. She could spin on her rotary disc or in her vestibular for hours.
So we know that, um, anytime you engage in something that activates your sensory system, okay, touch, smell, taste, hearing, sight, balance, posture, your autonomic nervous system responds to that, okay. um, it has to adapt because you're giving it input, okay. If you're doing something that you find enjoyable, right? Walking, running, spinning, jumping. Um, you get happy, right? We talked about the role of the autonomic nervous system in mood. B, your heart rate changes, your respiratory rate changes. If you do enough of your fun physical activity, um, you start to get hot, you start to get sweaty, right? So, we often wonder so I'll switch to my neurodevelopmental disabilities hat because that's the other realm of neurology in which I'm certified. We often wonder about children with developmental differences, autism being the biggest one. Why kids who have an autism spectrum diagnosis or other developmental difference engage in these repetitive behaviors that to us seem pointless, yet they get extraordinary pleasure from it. You know, if they're enjoying it, yeah, they're giving themselves some sort of sensory feedback that really helps them feel better. Um, that's most basic sense that I can make of it, right? It's like
Thank you.
people who enjoy running, right? I don't get it, but I understand that you may enjoy it.
So the next question, it's actually the person who asked the question before about sodium just
Okay,
wants to clarify.
sure.
So she's saying it's more that not about diet, but they notice that there's sudden sodium spikes when nothing in the diet changes. So wondering if those sodium spikes could be related to the autonomic dysfunction.
No idea. I have not yet thought about that until this question. So maybe an answer next time, but nothing that I can put together in my head immediately. More to
Okay.
read about.
Okay. The next question was sent directly to me, so I don't think you'll be able to see it, but could triggers for neurostorms be, wait, let me make sure I understand this. Okay. So I think the question is if a child. Okay, I'll just read it and we'll
Sure.
make. Yeah. So could triggers for neurostorms be the older the child gets, also increased anxiety panic attacks? So should you try to treat those with anti-anxiety medicines such as SSRIs?
Brilliant question. Thank you for that question. And that's something that I need to include moving forward. 100% yes. Okay. What we think of. Okay. So if we think about anxiety, anxiety is it's a cognitive process, right? We become worried, we become afraid, we become sort of at times paralyzed by a thought. Okay. What anxiety then does, so once you have that cognitive process going on, it triggers a whole flood of autonomic output. Okay. A panic attack is an autonomic response to an anxiety experience. So yes, that cascade, it's anxious, leading to the physiology of a panic attack, which looks like a mild form of PSH, to be perfectly honest. You just don't get the dystonia, but you get flushed, you sweat, heart rate increase, temperature goes up. Yes, and I need to include that moving forward because we see in patients as they get older, if they develop anxiety, treating the anxiety will often treat the problem. Okay. And, whenever I see a patient who's got anxiety that ends up with panic attacks, we use medications, in addition to the SSRIs that were mentioned, we use medications like propranolol, which works great for panic attacks. It's a beta blocker. It's an autonomic output. Basically, you decrease autonomic output by preventing the panic attacks. Okay. Yeah, brilliant question. Thank you for that.
And would that be the same if it's because I think with a lot of our patients, it's triggered, the anxiety is triggered by startles, by some kind of noise or something that they're not used to. Would it
Yeah.
theory also
So
help with those kinds of, yeah?
yeah, decreasing the anxious response to stimulus would help. Yes, because they are directly related.
Thank you. Okay, the next question. I know you didn't want to talk about specific medicines, but there's another question about clonidine. So if we're taking actually, this is the same person who asked the question about clonidine before. Um, so it's less about rescue, I guess, and more about could they go out like 2 hours before they're going out, if they know that going out is a trigger, could they give clonidine then and not just as an always on medication. More of a prophylactic than a rescue, I
Right.
guess.
In theory, um, yeah, in theory, it's worth a shot.
Okay, thank you. There's a comment here about appreciating how committed the clinicians are to and researchers to working together, including connecting you and Dr. Sands at Columbia about NMDA encephalitis. And then another question, are there any meds that make neurostorms worse? My daughter's been on
Vigabatrin.
vigabatrin for over a decade, which as a layperson understands, inhibits the breakdown of GABA. Is that a good or bad thing? We believe she has neurostorms, though no formal diagnosis. When we ask about her behaviors, I guess to their clinicians, they get shrugs.
Okay. So whenever I'm seeing a patient who has autonomic storming, I go through his or her medication list. And I go medication by medication, and I say, did you notice when you started this one, any change in frequency or severity of episodes? And I go medication by medication. And if I get a yes, I say, okay. And it can be different from patient to patient. So that's the way that I do it, is I go systematically and look at each individual medication and say, better, worse, no change with starting or adjusting the doses. Because of the complexity of this neurology and chemistry, it's always a different answer in terms of whether a medication did or didn't change the course of events. Yeah.
Well, thank you very much for this. We're actually over time, and the next sessions are starting
Oh,
in 2
sorry.
minutes. No, that's great. And I think are you joining us at the end of the day for Ask Me Anything? I think I
That's
saw
the
you on the.
plan.
Okay, that's great. So if there's more questions for Dr. Kaufman, you can ask them then. So thank you very much. Again, this was a terrific presentation, great Q&A, and we're so grateful for your ongoing commitment to helping our community. And I'm also glad to see how many physicians were in this session today, in addition to families and researchers. So thank you all
That's
for
great.
coming.
Bye.
Bye.